Thanks again for joining us for our virtual forum today, Harm Reduction 101, Myths, Truths, and Impact. We are pleased to introduce our presenter, one of Brightvie's state medical directors, Dr. Deana Kimes. Dr. Kimes?
Hi, everybody. Thanks so much for joining, because this is such an incredibly important topic, if not the most important topic in addiction medicine. I am Dr. Kimes. I'm the state medical director for Ohio for Brightview. I've been with them for about 5 years now. Before that, I came from emergency medicine, where I worked in 14 years, and I saw a lot of the negative consequences and repercussions from drug use. And it prompted me to really learn more about the medications. I can say that I wasn't always as understanding of the disease, nor of the people or the medications being prescribed. So I learned a lot. It actually opened my eyes to the disease process and led me to a fulfilling career in addiction medicine, which is the most rewarding job. So thanks everybody for joining us. Next slide. Our agenda for today, we're going to be talking about the disease of substance use disorder, comprehensive treatment, which uses the biopsychosocial model, evidence-based practices, including behavioral health services, medical interventions like MAT, medications for addiction treatment, and MOUD, which is medications for opiate use disorder. We'll be talking about harm reduction and recovery, myths and stigmas, how does it work, and what can you do? Next slide. Substance use is far-reaching, as are the effects. So 1 in 7 Americans experiences use disorder. So it affects about 21 million Americans, or 8% of the nation's population over the age of 12. Only around 10% seek treatment from the specialty sector each year. So we've got a long way to go to help patients who are suffering with substance use disorder. The effects are felt by not just the person, but the whole family and the whole community. It affects all ages, races, and socioeconomic groups. Next slide. Substance use disorder contribute to the consumption of time for people, increased involvement in dangerous activities or risky behavior that they normally wouldn't do, financial losses, emotional and physical debility, increased risk for communicable diseases such as HIV, hepatitis B and C, and STIs, significant comorbidities from examples of wounds, sepsis, cardiac diseases, high risk for incarceration and other legal issues, family and relationship dysfunction, widespread community effects, and increased need for social services. Next slide. It truly is a disease. It's a chronic disease involving complex interactions among brain circuitry, genetics, environments, and the individual's life experiences. It is not a character flaw. It's a disease that's preventable, it's biologic, it's treatable, and people can recover. People with substance use disorder use substances, engage in behaviors that they normally would not do. These behaviors become compulsive, and furthered by the biologic processes of the substances, they often continue despite risks and the consequences. A person with substance use disorder often continues to use substances to prevent sickness caused by the physical dependence, not just to get high. Genetics and environmental factors such as trauma certainly contribute to the development of substance use disorder. Next slide. Illustrating the biology of the disease, you can see these are functional MRI pictures. And a functional MRI is an MRI that actually maps the brain activity by detecting changes in blood flow associated with neural activity, which helps us to understand brain function. When specific areas of the brain are active, it consumes more oxygen, leading to increased blood flow in that region. And you can see that designated here by the bright colors. So on the left is the healthy brain, and on the right, 2 pictures are of a person with methamphetamine use disorder. In the middle, 1 month of abstinence can show some improvement, but after 14 months of abstinence, you can see a significant improvement. So I really hope this kind of illustrates that it is a biologic process. We can see this happening. Not only that, but people can recover and there's hope. Next slide. We use the biopsychosocial model. It's a comprehensive approach for assessing and treating substance use disorder and co-occurring illnesses. It's a holistic model of health that considers biological, psychological, and social factors in a person's life. The biological component addresses the psychological aspects of a person's health, including genetic predispositions that may increase vulnerability to substance use, the presence of physical illnesses or disabilities that can affect or be affected by the substance use, alterations in brain function and chemistry caused by substance use, intoxication, and of course, withdrawal, which is the body's physical response to ceasing substance use when it's dependent on it. The psychological component focuses on the individual's thoughts, emotions, and behaviors, which contribute to the development and maintenance of substance use disorders. And it includes the presence of co-occurring mental health conditions, such as anxiety, depression, and PTSD. Cognitive state, the person's thought patterns, readiness to change. Past or present trauma, which is a major risk factor for addiction. Coping skills, the patient's methods for dealing with stresses or triggers. The social factors consider the influence of the person's environment and relationships on their substance use. Factors include environment, which is social norms, accessibility of substances, and the individual's recovery or living situation. Relationships, influence from family, peers, and social support systems or lack thereof. Socioeconomic status, so factors such as housing, employment, income can increase or decrease the risk of substance abuse. Cultural beliefs and practices related to substance use also are a consideration. Next slide. So what is the medication for addiction treatment? It's part of a comprehensive treatment program. Medications for addiction treatment, or MAT, or medications for the opiate use disorder, MOUD, alleviate withdrawal symptoms and cravings. So it allows the person to focus on recovery and feel more like themselves. It reduces overdoses. It reduces the risk of returning to use. It increases patients in treatment. It sustains recovery rates are much higher. I hear the question often, are you truly sober if the person truly sober if they're taking MAT? When craving stops, so do the person's compulsive, unsafe, and drug-seeking behaviors, trading life-threatening illegal substance use for FDA-approved medications. So it's definitely a big no. It is not trading one drug for another, and they are sober. They're using FDA-approved medications. Next slide. Evidence-based treatment works. Evidence-based treatment refers to treatment methodologies supported by rigorous scientific research, demonstrating their effectiveness. A successful comprehensive approach includes these that are tailored to the individual patient needs. The holistic approach includes counseling, medications, and harm reduction. There are 3 FDA-approved medications for opiate use disorder: methadone, buprenorphine naloxone product, naltrexone. There are also 3 FDA-approved medications for alcohol use disorder: naltrexone, acamprosate, and disulfiram. Currently, there are no FDA-approved medications, unfortunately, for disorders such as stimulants or cannabis. And the length of time that a person is on these medications is very individualized and differs widely. It really depends on the genetic factors, how long that they have used, and at what age they started, and several other factors. Treatment's definitely not a one-size-fits-all, and it's nice to have these tools in our toolbox because not every product works for every person as well. We can go over more on these a little bit later, and certainly if there's questions, I'd be happy to delve into those later on. Next slide. There are a lot of myths involved with opiate use disorder and substance use disorder in general, that MOUD is trading one drug for another. They're not really in recovery, and utilizing those means that they're not serious about quitting. Some feel like, well, if one treatment worked for them, or at total abstinence or quitting cold turkey worked for them, it's got to work for everybody. It's not a one size fits all. MOUD undermines recovery. An abstinent base is more effective than using medications for opiate use disorder. People who use MOUD illicitly are doing so just to get high. And that MOUD is harmful to a fetus and should not be used in pregnancy. We really need to dispel these myths so that way we can get more people into treatment and understand the disease and the process and the treatment. Medication for opiate use disorder normalizes the neurochemical disruptions in the brain and helps the brain to stabilize. It eliminates withdrawal and opioid cravings at proper doses, helping patients through recovery. Every patient is different. What worked for one may not work for another. MOUD assists in recovery. It reduces criminal behavior and the chances of contracting infectious diseases. It decreases illicit opiate use. It reduces overdoses and overdose-related deaths. Most people who use MOUD that they're purchasing on the street are doing so to avoid withdrawal and to stop using other opioids, not to get high. Buprenorphine and methadone are safe for pregnant women and breastfeeding mothers. The American College of Obstetrics and Gynecology recommends MOUD for pregnant women with opiate use disorder. Next slide. Harm reduction. SAMHSA is the society it stands for the Substance Abuse and Mental Health Services Administration. It defines harm reduction as practical, transformative approach incorporating community-driven public health strategies, including prevention, risk reduction, and health promotion, to empower people who use drugs and their families with the option to live healthier, self-directed, and purpose-filled lives. Harm reduction opens the door to more options for people who use drugs, for whom traditional treatment and approaches are inaccessible, ineffective, or inappropriate, and who want to make healthier choices in their life and health. Harm reduction access is consistently shown to improve individual and community outcomes. It reduces harm, and it can take many forms for many different people at different points, including the use of medications to treat substance use disorders. It's inclusive of abstinence as a chosen pathway, but it's not a coerced pathway. SAMHSA conceptualizes harm reduction as being a set of services, an approach, and a type of organization. Harm reduction is also part of the continuum of care and comprehensive strategy that includes prevention, treatment, recovery, and health promotion. Prevention, particularly primary prevention, seeks to prevent problems before they start. This means preventing exposure to substances, screening and intervening with for early misuse, reducing risk factors, strengthening protective factors, and strengthening protective factors individually and in the community and societal levels. Prevention seeks to stop or delay the progression of substance use to substance use disorder, as well as prevent other harms associated with substance use. Harm reduction is practical in its understanding, and the acceptance of drug use and its other behaviors carry risks, but it responds in a compassionate and life-saving manner. Next slide. There are many types of harm reduction programs. So to name a few, there are public health program alternatives to arrest and legal involvement. There are syringe service programs, mobile harm reduction units. There's overdose education and detection, fentanyl, or xylazine test strips. These help keep people who use drugs alive with less injuries or illness, minimize health risks, and alert people who use drugs to other treatment options. Syringe service programs and safer smoking supplies reduce disease prevention. As permitted by law, no federal funding is used to purchase pipes. Grants explicitly prohibit the use of federal funds for the use of drug paraphernalia. There are many other types of harm reduction program examples. Just to name a few, there are integrated reproductive health education services, supplies, and sexually transmitted infection screening, treatment, and prevention. There's on-site access for immediate accessible referral to basic wound supplies and services in the community. Healthcare settings and providers informed with and using harm reduction principles and pillars for the people they serve. Non-punitive care and offering consistent care in a non-stigmatizing, non-judgmental manner. And do not refuse healthcare based on stigma or people's beliefs about drug use. We're advancing with reducing barriers to these medications. There is flexible take-homes for methadone medication. And I'm happy to say that Ohio has adopted the federal guidelines for flexible methadone take-homes so that those in which the benefit outweighs the risks, they do not have to come daily to dose for methadone. This will help people get on with their lives, get jobs, be able to purchase transportation, provide for the families, be a contributing community member, and get their lives back. Additional harm reduction programs include health hubs for people who use drugs, integrated HIV, viral hepatitis, and healthcare services, warm handoffs from emergency departments with low barrier MOUD initiation and post-overdose services, seamless coordination of care for individuals leaving carceral settings and treatment settings that do not offer MAT or MOUD. These people are at greatly heightened risk for overdose fatality when released back into the community. They have decreased tolerance, and using the same amount of drug that they previously used can kill them. Next slide. Harm reduction does work. Syringe service programs, AKA clean needle programs, reduce the disease transmission. Sites often include overdose education and naloxone. Individuals who use SSPs are 5 times more likely to enter drug treatment, 3 times more likely to stop using drugs. Naloxone distribution at sites has significantly reduced overdose death rates. I would love it if everybody actually carried naloxone with them. You never know where you're going to see somebody who may have overdosed. A study compared with the number of improperly disposed syringes to self-reported disposal practices in a city with SSPs compared to a city without SSPs. There are higher rates of safe disposal practices reported in the cities that have SSPs, and 8 times more improperly disposed of needles in the cities without SSPs. This definitely helps not only the patients, but the community. Next slide, please. There are supervised injection sites with trained professionals who can intervene in case of an overdose. This also helps direct patients to treatment facilities, helping patients with substance use disorder do it safely. There are mobile harm reduction units, literally meeting people where they are, offering supplies like test strips, necessities like food and clothing, as well as trauma-informed counseling. Making referrals to drug treatment, medical care, and social services occurs with these programs. Next slide. Naloxone can now be purchased over the counter. Secondary distribution of naloxone kits has empowered community members to administer naloxone to others. This includes targeting distribution to locations where individuals have a high risk of opioid overdose. Fentanyl and xylazine test strips help promote safer drug behaviors, less overdoses, less fatalities, and less complicated wounds that are associated with xylazine. Next slide. What is naloxone? It's a generic name, and there are several brand names available. One or two are Narcan and Cloxado. It's a life-saving emergency treatment that reverses opioid overdose. It typically wears off after 30 to 45 minutes. So often the drugs such as fentanyl last a lot longer. So a patient has to be monitored and often given additional doses. It's an opioid antagonist. So it attaches to the opioid receptor and effectively blocks the effect of the receptor. There's no abuse potential with naloxone. It's not a controlled substance. It can be administered by individuals with or without medical training to help reduce opioid overdoses. It's available in two forms. So we mostly see the nasal spray, and it's also available in injectable, typically given by EMS or hospitals. Naloxone can start working as quickly as 2 to 3 minutes, but it often requires repeated doses, especially with fentanyl use. So when using naloxone, after waiting 2 to 3 minutes, if there's no response, give another dose until the patient is breathing. But always call EMS after an overdose. As we talked earlier, the Narcan actually wears off before the other drugs do. So the person is at significant risk of going back into overdose when everybody leaves. Stay with the person until EMS arrives to monitor them to ensure the breathing does not slow or stop. Next slide. There are 3 different types of stigma that all affect patients: social and public stigma, structural stigma, and self-stigma. Social and public include negative stereotypes that are held by society. Structural is discriminatory laws and policies that hinder access to treatment and support services. And self-stigma, internalized negative beliefs that lead individuals to feel shame and fear, discouraging them from seeking help. Patients who I've seen so often have this self-stigma and call themselves addicts. They are hopeless, and they've grown up feeling this. Even their most close relationships and even parents have ingrained the stigma into them. So we really want to reverse that, empower people to have the confidence that they can get treated and they can heal. All of these contribute to people who use drugs from seeking services and remaining in treatment. Next slide. There's reduced access to treatment and recovery services due to stigma, avoidance of help due to fear, hopelessness, and judgment, delays in diagnosis and care, higher rates of morbidity and mortality, lower quality of care in healthcare settings when providers have the stigma against the patients that they're treating, isolation, hopelessness leads to increased substance use often. Barriers to employment and social necessities occur because of stigma. Next slide. We really want to stop the stigma, reducing stigma in practice. We want to lead by example. Use respectful and non-judgmental communication. Educate staff, patients in the community about substance use disorder as the disease. Encourage a patient through their journey in recovery. Given the chronicity of the disease, use motivational communication techniques and understanding ways to help those who have returned to use. Provide trauma-informed, patient-centered care. reduce barriers to substance use disorder treatment and medications, assist with case management to reduce social barriers, and advocate for policy change. Next slide, please. Overcoming stigma is so important. We often use stigmatizing language and we don't even know it. There are many terms that we used to use that have fallen out of favor. So instead of saying addict, we want to say a person with a use disorder. Instead of saying alcoholic, person with an alcohol use disorder. Former addict may sound like you're not being stigmatizing, but it truly is. A person in recovery or a person in remission from a substance use disorder is a much better term to use. Shooting up is a term that we shouldn't use, using IV drug use or using intravenously. Being in or going to rehab or detox are terms that we don't typically use anymore. We should be using participating in a recovery program or withdrawal management. Instead of saying addicted baby, we would say baby with neonatal opioid withdrawal. Instead of using terms like clean or dirty, referring to either the person themselves or the specimen that they're giving, using terms such as substance-free or testing negative for substances, or testing positive instead of dirty, or unexpected results. Instead of using the term relapse, using return to use. And why do we use these languages? It truly does help the person feel more like a person. Person first language shows that the person having the problem rather than being the problem. We do not want to decrease a patient's sense of hope or self-efficacy for change. We want to use clinically accurate, non-stigmatizing terminology the same way we would any other medical condition. People do not choose to have a substance use disorder, just like they don't choose to have diabetes or high blood pressure. Next slide, please. What can recovery do for a community? It not just helps the patient, it saves lives, but it also prevents drug-related deaths. These are somebody's sons, daughters, mothers, fathers, grandfathers, and grandmothers. We want to increase awareness and access to healthcare, social services, and treatment. It truly reduces crime. Individuals in treatment are less likely to engage in illegal activities. Most often, they're engaging those illegal activities just to sustain the substances that they need to keep them from being sick. This will create safer communities. MOUD treatment can help individuals stabilize their lives, seek employment, and become productive members of society. Improve public health. So access to healthcare reduces the spread of blood-borne illnesses such as HIV, hepatitis B and C, unwanted pregnancies, or children in foster care. It improves public health and safety. So it truly does help the whole community as well. Next slide. So communities could work together to reduce death and disability with increased education and awareness to the vulnerable populations, increasing screening opportunities, more outreach, and boots on the ground, more support from social services, legislation, and communities, and providing less stigma attached to the disease. Next slide, please. Providers can help by hiring and employing staff with lived or living involve them in planning, implementation, and evaluation of services. We've got a lot of patients who have gone on to help others by being peer support. Social support, providing access to nutritional assistance, clothing, temporary shelter and housing, low barrier to access to ensure warm handoff to and from emergency department programs, to MOUD treatment, and post-overdose care. access online or other languages. So we want to expand telehealth, also addressing technology for literacy and non-English speaking patients. For justice involves seamlessly coordinating care for individuals leaving carceral situations and treatment settings that don't offer continuation of MAT. Spread awareness and promote education on the value of harm reduction services. There are many of us that have gone into addiction medicine for many different reasons, and some are even previous people who used and had substance use disorder. They serve. Next slide. The takeaways. I hope it's a little bit more understandable that substance use disorder is a chronic disease. It's not a character flaw. And stigma is a major barrier to recovery. Simple language and attitudes truly matter. We all play a role in reducing stigma. So when we change the way that we talk about addiction, we actually change lives. Harm reduction is a community approach emphasizing kindness, education, and promoting autonomy in all interactions with people using substances. Next slide.
All right.
Thank you so much, and I'm happy to answer any questions.
Thank you, Dr. Kimes. We are going to go ahead with the Q&A portion of today's discussion. To all of our attendees, feel free to drop any questions you may have in the chat, and we will get to as many as we can. To kick things off, Dr. Kimes, there's a lot of misinformation out there about harm reduction, even in the recovery field. How can we help fellow addiction treatment providers and staff address their own stigma?
Yeah, that's a good question, because it does occur very often. Medicine is an ever-evolving specialty, and addiction medicine is no exception. Staying abreast of the latest studies and understanding the validity of those studies, continuing education, and keeping up with main addiction societies such as SAMHSA and ASAM provide us with information and education to help people who use drugs by using the best practice. So by always learning, we always understand how we can reduce barriers and reduce our own stigma. We often don't recognize what we're even saying and not understanding that it is affecting people the way it does.
Can you talk, I know we touched on it a little bit, but could you speak a little bit about harm reduction for pregnant patients? We know they can be on MOUD, but can you talk a little bit about what are the potential effects on the baby?
Yeah, absolutely. This is a big topic, and we could probably talk all day about this. All patients, including pregnant patients with opiate use disorder, would be educated on MOUD options, the risks and benefits, in order to help them make the best decision for themselves and the health of their baby. Additionally, there are education, we provide education on the possibility of neonatal opioid withdrawal syndrome, which is a possibility. However, it is very easily treated, and it is much safer for the baby if a woman is on MOUD than using illicit substances. So while infants exposed to methadone or buprenorphine may experience neonatal abstinence syndrome or NALS and neonatal opiate withdrawal syndrome, this is possibly expected and treatable. So concern over these should not prevent providers from prescribing this to pregnant patients. For infants are swaddling, breastfeeding, skin-to-skin contact, and sometimes medications. There's no known lasting effects or physical or intellectual problems for babies born to people who were on methadone or buprenorphine. We encourage collaboration with OB and the delivery team, and there's no contraindication to breastfeeding with buprenorphine or methadone. The risks of continued drug use are significant to the mother and the baby, both pre and post-delivery. So MOUD is highly recommended as a safe choice. As stated before, the American College of Obstetrics and Gynecology strongly recommends using opioid agonists like buprenorphine and methadone as a treatment for those with opiate use disorder during pregnancy. They prevent withdrawal symptoms, reduce cravings, and is associated with better maternal and neonatal outcomes compared with those who are untreated. The medications are safe and effective. There's it definitely does improve the maternal and fetal health outcomes. And untreated opiate use disorder can lead to more severe complications such as fetal distress, intrauterine growth restriction, preterm labor, and stillbirth. Discontinuing MOUD actually increases the risk of relapse, which can lead to worsening outcomes for both the pregnant person and the baby. ACOG recommends mostly methadone and buprenorphine first line in pregnancy and not naltrexone, because a person has to actually be in withdrawal to be able to be placed and have a week's worth of abstinence at least before they are able to be put on naltrexone. And because of the risks of that, not only that, but also the suggestion that there may be some lack of clinical data concerning potential fetal effects of naltrexone in pregnancy, it's not the first line choice like buprenorphine or methadone.
We're going to take some questions from the chat now, Dr. Kimes. We have an attendee asking if there are any currently approved MAT medications for methamphetamine use or cocaine use, or will there be any in the future?
I hope so. I hope in the future, but there are no FDA approved medications for a stimulant use disorder or cannabis use disorder. We have been using some off-label medications for it and have had some anecdotal success. There are studies that are more studies are being done too. So we hope that be able to have more possibilities of having FDA approved drugs for these substances in the future. It's a good question.
How would we go about getting information to those active in their addiction? How do we find them in the community to educate them on these great harm reduction practices?
I think really a lot of us may know where some of those areas in the community are where we could concentrate our efforts. However, there are so many Americans that are afflicted with substance use disorder from all socioeconomic groups. So it could be your neighbor next door. So really just marketing and using less stigmatizing marketing and truly creating more options for patients. So some may not seek treatment because they are worried that somebody's going to recognize them or that they're going to be treated poorly, which is most often, unfortunately, the case when they go to treatment, that they think they're going to be treated poorly. So I think the more that we can do to welcome people into care and treat them with non-stigmatizing best practices, word spreads as well. So I really wish we could have more funding to market to everybody to help them understand where they can go to get help.
All right, going back to MOUD for just a second, can you speak to the length of treatment a little bit? The question we have specifically is it a goal of treatment to eventually wean the user off of MAT treatment, or is it a lifelong approach?
That's an excellent question. There's a lot of people who will tell us when they want to start to wean. So that's what typically happens. So most often people don't want to be on a medication for their life. So they will start to understand when they are ready to wean. And we help them through that process. One, by seeing if they have that holistic care, they've already had adjustments to their socioeconomic factors that play into it, their mental health, and also those biological conditions that they may have, to reduce the triggers and reduce the chances of them returning to use. Once they're in that stabilized period, we talk with patients about tapering, and we do it slow. So the person off of the medication, typically it took years to develop the disease. So it sometimes takes some time to wean a person off successfully and without discomfort. Some patients who have started using substances at a very young age, before the brain was developed, may require medication for a lot longer than someone who just started when they were after the age of 25, when the brain was more fully developed. So it really widely ranges. That's a very good question. So some people may be on it for a very long time as well.
Going back to pregnant patients, what can we do to help reduce the stigma of MAT use during pregnancy and breastfeeding? We've got people asking specifically, are there any references or documents that you would recommend people use to support any of this data?
Yes, the American College of Obstetrics and Gynecology published a paper, and we can, I'll see if that is actually noted in the slides here. If not, we can add that on here, but they are pretty much the go-to, if you will, for recommendations. And in their paper, they cite their recommendations for using MOUD. I think that really helping pregnant patients who are fearful that they're going to have their child taken away from them is the biggest barrier that I see. So they are afraid that they're going to be reported. They're also afraid that if they're on medications, that, which is inordinately sad, because women are then also afraid to tell their providers, their obstetrician, that they've had a history, for fear of loss of their child or being stigmatized. So that actually leads to less treatment. I think asking yes or no questions is something that we should avoid, but use motivational interviewing techniques to try to evaluate pregnant people, so that way they're more apt to be forthcoming with their use to seek help, because most want that help. And that's a really opportune time that we can use to get people into treatment when they're pregnant. They're highly motivated, much more so than they may have been before pregnancy.
With some recent SAMHSA changes, how are harm reduction techniques being impacted? How can we help community members or even elected officials see these programs as being beneficial for communities?
Yeah, substance use disorder treatment and harm reduction programs definitely have been proven to reduce illicit drug use and behaviors associated with drug use. It reduces diseases associated with drug use that cost additional resources in the community. We want to get people who use drugs their life back, so that they can return to contributing to the community.
Can you speak to the idea that harm reduction looks different in communities of color? Are there any differences, and what are those?
Yeah, certainly racial and ethnic groups have disparities in treatment and harm reduction programs. Many people in these groups face additional stigma, not just for drug use, but because of their racial or ethnic group. There's bias and there's socioeconomic factors too that play into that as well, that prevent them from seeking services. This is also greatly affected by the availability in their areas. Funding makes a difference as well, and culturally driven treatment is really important in people with that in different racial and ethnic groups. Some reasons noted by SAMHSA in their report of barriers is cost or insurance, a low perceived need, prejudice and discrimination, structural barriers, and then those who are maybe not ready to stop using completely. So using harm reduction in these cases is extraordinarily important.
Alrighty, we have a question in the chat, interested in your perspective on how can we view harm reduction as a tool if we're noticing patients in a clinic with lower engagement after harm reduction practices have been implemented. So I guess, can you speak a little bit to people who might be noticing that in their clinics, or people who might be fearful that their treatment center is just turning into a bit of a dosing clinic?
I think they're at is reducing engagement isn't supported in the data. The harm reduction programs have been studied and are definitely beneficial to typically keeping the patient in service. So I think we need to think less of what we think is expected and more of what the patient feels is appropriate for them at the time in their life. So forcing somebody into a certain amount of treatment may not be the way to go about it long term. So we may feel that if we say this service is what's appropriate, and if they're not meeting that engagement, that they're somehow fair, is something that we should get out of the mindset of thinking. If the person is doing well, doing better, using less substances, and doing so in a more healthy way, that's a win. So I always say that if a person is not, I hate the word almost, compliant with their appointments, and they're coming in every once in a while, we still want to meet that person with respect and not stigmatizing or authoritative behavior. So we want to encourage them to keep coming back. So as long as that person's alive and they come back, that's again a win. So we want to, every time they take a step across a substance use disorder treatment's door, take pride in the fact that that person is seeking your help and that you're helping them.
I think this last question is a good one to end on. Dr. Kimes, if you were going to explain harm reduction to someone that was completely clueless about it, and maybe they were hearing about it for the very first time, how would you do it?
Yeah, helping to understand that harm reduction, again, from the SAMHSA definition, is wide ranging. It's not only the programs, but it's the way we treat patients when they're in service. It's helping people who use drugs to reduce the chance of death and additional disorders that are associated with drug use. So if we can prevent the bloodborne diseases, if we can prevent wounds, if we can prevent overdoses, that's what we want to think about what we're doing with harm reduction. And it may not always mean abstinence at that time in that person's life. If we can reduce the risks, that's what harm reduction is for. You know, we do have FDA-approved medications to treat opiate use disorder, and programs reduce infections that reduce overdose, and we have reversal agents for overdose, opiate overdose. So no one should die from this treatable disease.